All right, this is a practice presentation for the Society for Critical Care Medicine. So, contestation of brain death. I have nothing to disclose, and we're going to talk about the legal rights and responsibilities of critical care clinicians regarding brain death. And I'm going to focus on 7 key points of contestation. And we're going to move pretty much chronologically. So let's say that you suspect your patient is brain dead. You do the bedside clinical exam, and you want to do an apnea test to confirm. So the first issue, the first point of contestation is, do you need consent to do that testing? Right? This has been the subject of a lot of conflict and litigation. So the guidelines, AAN, AAP guidelines, as well as the World Brain Death Project and many other guidelines, say no, you do not need consent. The law is mostly in accord with that. It says generally you should notify the family about the testing, but you don't need consent. So this has been recently confirmed in Virginia, in Nevada, in New York, in Georgia, and in Texas. But some states say that you do need consent for brain death testing. So if you don't get consent, then you can't do the testing. So in California, the courts have issued a number of injunctions in this case, and more recently in this case. In Montana, this little boy had drowned. He goes to this hospital. The clinicians do bedside clinical exam, think that he's probably brain dead. They want to do an apnea test to confirm. But his mother says, no, can't do that. So the hospital goes to court and says, Judge, we have a patient in our hospital and we need to know if he's alive or dead. Court says, no, your request permitting testing is denied. Right? The mother has sole authority to make medical decisions, including brain functionality exams. So there's a split across the country. The majority rule is that consent is not needed, but there's a minority rule that consent is required. That's the first point of contestation. Do you need consent for brain death testing? The second point of contestation regards accommodation for brain death testing. So let's say that you were planning to do this test today, but the family wants you to wait until Thursday. So the guidelines say that not only do clinicians have the moral authority to test without informed consent, but they have a professional responsibility to do so. You ought to do it. The law is not so demanding, right? So generally you may delay testing. But in New York, according to this recent case, you must delay testing, at least sometimes, when the family has a religious, moral reason for that. No other state addresses accommodation before brain death. So New York is all alone on that. That's the second point of contestation. Must you provide accommodation for brain death testing? So let's fast forward a little bit now. Let's say that you've done the tests and the patient is brain dead. So can you withdraw organ-sustaining treatment? Yes. The guidelines across the world are consistent that after brain death, medical support should be discontinued. All medical interventions should be withdrawn. The law is 100% in accord with those guidelines. Right? Consent is not required. Once somebody is dead, they're not a patient. And if they're not a patient, then you don't owe them treatment duties, like getting consent. Those are all turned off when the patient died. That's a very bright line rule in the law. That's the third point of contestation. May you withdraw organ-sustaining treatment after brain death? And the answer is yes. Parents have limited post-brain death rights. But there are two exceptions. And that brings us to our fourth point of contestation. Is the patient exempt from brain death? In New Jersey, since 1991, the law has provided that death shall not be declared if that would violate the patient's religious beliefs. Right? You may not withdraw organ-sustaining treatment because of brain death. The patient may satisfy brain death criteria, but you may not declare or pronounce death until the patient meets cardiopulmonary criteria. So for some patients, brain death is not legal death. In the 2020s, there was an effort to copy and paste this New Jersey approach in the Texas legislature and in a number of cases all across the country, like this one and others. Those all failed, and so today New Jersey remains all alone. So what's the upshot? There's no duty to continue organ-sustaining treatment indefinitely except in New Jersey. That's the fourth point of contestation. Is the patient exempt from brain death? The fifth point of contestation regards accommodation before withdrawing treatment. Now, accommodation is not the same thing as exemption. In New Jersey, patients with religious objections are not dead legally. So, there's an indefinite duty to continue organ-sustaining treatment until death by circulatory criteria. In other states, every other state, patients who meet brain death are dead. But there's often a temporary duty to continue organ-sustaining treatment. So in California, for example, the law for a number of years provides that hospitals must offer reasonable accommodation. What does that mean? Well, it means you must continue previously ordered cardiopulmonary support. No other medical intervention is required. And for how long do you have to do that? For a reasonably brief period, which is defined as the amount of time necessary to gather the family at the patient's bedside. In fact, the law defers and delegates to hospitals on this and just says adopt a policy for providing the family with a reasonably brief period. So you get to define it. Most hospitals pick up to 24 hours. So that's California. A very similar set of rules in New York. What about other states? Well, there's no statute or regulation, but it is the common custom and practice. You might say it is the standard of care. So what's the upshot here? Well, there's a duty to continue organ-sustaining treatment for a reasonably brief period, probably around 24 hours. And of course, you don't need to, but you may provide for a longer period of time. That's the fifth point of contestation. Must you offer accommodation after brain death? So let's stop right there and recap. So I've given you 4 points of contestation. Before brain death determination, questions are, do you need consent to do the testing, and must you offer an accommodation? After determination of brain death, the questions are, must you honor religious exemption, and must you offer an accommodation? Now, there's variability in how those questions are answered. Different states give different answers. And that's not good. But there's still two more points of contestation. So the sixth point is about accepted medical standards. So the Uniform Determination of Death Act, the UDDA, which is the law on brain death in almost all U.S. jurisdictions, says that you must determine brain death in accordance with accepted medical standards. But which medical standards are the accepted ones? Unfortunately, there's significant variability across the country. Lack of uniformity in brain death determination policies. And this has been measured again and again and again and published on. And this really reached a real head in this case where the Supreme Court of Nevada said that the American Academy of Neurology guidelines are not accepted medical standards, right? And that really, I think, shocked the clinicians in Nevada, at least. And so to fix that, they changed the law. And some other states changed the law. And what they did is they point now specifically to the AAN-AAP guidelines. So there's no uncertainty about which guidelines to use, right? Saying to clinicians, use these standards when determining brain death. So they did that in Nevada, in New York, and in New Jersey. But that's only 3 states, right? What are the accepted medical standards in the other 53 jurisdictions? Not so clear. So that's the 6th point of contestation. Are you using the right standards to determine brain death? And then finally, the 7th point of contestation regards a medical legal gap, right? There's a mismatch. The law, the UDDA, says that there must be irreversible cessation of all functions of the entire brain. But the AAN-AAP guidelines say that neuroendocrine function can persist, and that's not inconsistent with the whole brain standard of death. So the guidelines ignore ongoing function of the hypothalamus, even though it is part of the brain. And so there's this gap between the medical criteria and the legal standard, right? And so the charge is that you're not measuring irreversible cessation of all functions of the entire brain. And this has been litigated a number of times in the Jahi McMath case and in other cases around the country, right? Saying that AAN-AAP has downgraded the test from whole brain death down to partial brain death. And that's not what the law says. That's the 7th point of contestation, a mismatch between legal standards and medical criteria, right? So to wrap up, I've given you 7 points of contestation, and we could put these into 2 groups, right? In group 1, the family wants a special exception, right? Before brain death, they want you to either omit testing or delay testing. After brain death, they want either an indefinite accommodation or at least a temporary accommodation. In group 2, though, they're not asking for a special exception. They're alleging there is an error. There's something wrong with the determination. Right? That the American Academy of Neurology doesn't match the law, right? Because you're not using accepted medical standards to determine death. Or they're alleging that it doesn't match the law because you're not measuring the cessation of all functions of the entire brain. In response to these 7 points of contestation, the law in some situations, in some jurisdictions, offers no answers, or it's offering inconsistent answers. In 1979, we had a similar problem. And so to fix it, Jimmy Carter brought together the task force that wrote the UDDA. So we thought, we'll take the same path to fix the problems of today. So between 2020 and 2023, we worked to create a revised Uniform Determination of Death Act, an RUDDA. But that didn't work out. So we are still left with some uncertainty and variability. And that creates public mistrust, and that creates conflict. Thank you.